Hey everyone, welcome to Folds and Curves. I'm your host, Mo Kashkush. We have a very special guest today, Dr. Inma Hernandez. Dr. Hernandez is one of the most impressive people I know, receiving 2 doctorate degrees by the age of 25. One as a PharmD and one as a PhD in Health Services Research and Policy. She's now a professor at the University of Pittsburgh, focusing on the related fields of pharmacoepidemiology, pharmaceutical outcomes and policy research, pharmacoeconomics, and pharmacoanalytics. Her groundbreaking work on drug pricing and anticoagulants landed her on the Forbes 30 under 30 healthcare list, among about 20 other honors, like being a fellow of the American College of Cardiology and being a fellow at the American Heart Association, as well as dozens and dozens of top-tier publications. Now, today we'll be talking about her recent work with the West Health Policy Center to develop a county-level map of the health infrastructure in the United States, specifically as it relates to vaccine administration sites. Now, this work is extremely timely, insightful, and reveals important disparities in health equity. So please check it out and share the links in the show notes to take a look at the interactive dashboard that they've created. Let's get started. Okay, Dr. Hernandez, thank you for joining me.
Thank you for having me.
Yeah, it's an absolute honor. So you recently did a really incredible study, really timely, especially as more and more vaccines are being given every day and new ones are being sent to the FDA. And you really looked at the entire United States and sort of the healthcare infrastructure in the United States. And you looked at it in relationship to different groups, different demographics, including older individuals, different racial groups. And I just wanted to hear from you if you could give us an overview of the study that you did, the VaxMap.
Yeah, so I think that was a great summary. We got a synthetic population of the United States and we mapped that. And then we mapped all community pharmacies that provide immunization services, hospital outpatient departments, rural health clinics, and federally qualified health centers. And then we did the geographic information analysis, which means that for each person, we mapped in the road network, which was the closest facility, and we measured the driving distance. And now we are reporting estimates mostly at the county and the state level to demonstrate in which counties the local healthcare infrastructure may be not enough or may not be as easily accessible to. So the output from this analysis is that for each county, we are looking at the number of facilities per 10,000 people. We have the average driving distance, and we also have the proportion of the population that is farther than 10 miles. Mm-hmm. We also thought that it was important to measure racial disparities because we believe that health equity in this vaccine rollout process is going to be of the essence. So we identify counties where Black patients, or rather Black residents, are at higher risk of having to drive more than 1 mile or 10 miles than white residents. And we did these 2 thresholds, 1 mile and 10 mile, thinking that 10 miles may be more relevant in rural counties and 1 miles may be more relevant in urban counties. Mm-hmm. And we found that there's a lot of variability. We found that there's counties in the United States where the problem is that we may not have enough facilities for the population that we need to vaccinate. Then we have other counties where maybe the problem is that patients are very far, meaning that they may have to drive longer distances, which may be an issue in accessing the vaccine, especially for folks that are older or that may not have vehicles. And then we have counties where I think the major problem is that there's major racial disparities in access. And I think these counties are concentrated in some of the major metropolitan areas, especially in the Southeast, like Atlanta, some of the Texan cities, and New Orleans.
Okay, so this is like an analysis of the existing healthcare infrastructure, right? Not necessarily of the vaccines, how they're being distributed, but just the sites at which they're likely to be used.
That's a very good point. The first point is that we did not include some of the non-conventional vaccination centers, like stadiums or, like mass immunization clinics or travel vans, because what we wanted to do with this was to actually figure out in which counties we need to put, these additional vaccination spots. So we've been asked a few times why we haven't included the stadiums or convention centers. And it's because we actually want our results to inform where those stadiums or convention centers need to be located, meaning where those additional administration facilities need to be established. Yeah. And the second point, as you're saying, is that unfortunately, we didn't have data when we were doing this as of which facilities were actually going to get the vaccine. And these geographic information systems is quite complex in the sense that it took 4 weeks of running. Like the analysis actually took 4 weeks of running because we literally have to calculate for each person the distance. And it's so specific that for each person, we even know if they could have to leave the car from the left or from the right to get to a facility. So it's terribly specific. And for that reason, it takes so long to run. So we cannot update the results each week as there's new data from which facilities are going to get the vaccine because we just take too long in doing it. And I think the point why we did this, and it gets back to why we are looking at the local infrastructure, is that we wanted this to be used as a planning tool, guiding county and state health officials in figuring out where additional resources may be needed for a timely and equitable vaccine distribution. So I guess this is not that much about measuring where the vaccines currently are going, but rather where do we need additional resources to make sure we can reach herd immunity and an equitable distribution as fast as possible.
Yeah, I think it's really important because you often, like in the popular media, you see total number of vaccines per day, total number of infections or deaths per day, but you really don't get any like granularity on where any of this is occurring or who's getting more of what or who's being affected by the disease more. And I really like the description you gave of, being able to turn left or right and seeing like where that person has to go to get to that potential vaccine clinic. Because I think that paints a picture. Do you think we should look at the map now? I think like your description really fits well with the map.
I think that could be terrific. VaxMap is a open access interactive dashboard, and I think we can share with our listeners the link so that they can use it themselves.
Yeah, and I'll include it in the show notes so that they have the link.
Perfect. So when you go to the link of VaxMap, first of all, you have here a link to the white paper. I know that people may not be interested in a 22-page white paper, but if anybody is actually thinking about what are the results behind these dashboards that we have here, the white paper is the place to go. Anyway, so the first dashboard that we built is a dashboard at the county level. And basically, this is showing important statistics at the county level that are the product of our analysis. So the first one is facility density, which we are defining as number of facilities per 10,000 people. And you can see that the counties with the lowest facility density tend to be concentrated in Kansas, Nebraska, Montana. Then we also show the proportion of the population with more than 10 miles from a facility, which has a similar distribution. And I think this is concerning because it shows that there's states here and counties that we call they are at very high risk because they have these two problems of both a low facility density coupled with a high proportion of the population far away from facilities. And actually, we have defined a risk score, which is the combination of the facility density and the proportion of population more than 10 miles. So this risk score stratifies county by risk of access to COVID vaccine, again, based on those two metrics. And we are also showing here a map that I know looks very wide, but this is just because we are displaying in which counties Black residents have a significantly higher risk of being farther away from 10 miles than white residents. So if a county is white, it means that either we didn't see a disparity or we didn't have enough data to call this a disparity. And that's important because our analysis is based on a 1% sample. So it's not the full population, and we wanted to be conservative and making sure we had enough sample size to look at these numbers. And then the second dashboard, which I think it may be a bit more fun, it goes all the way to the street level, and it shows the location of the facilities. So for instance, if we go to our home state of Pennsylvania, we can click in each county, and we can see, as you see, like some of the statistics on the upper left corner for the county, like the facility density, proportion of population more than 10 miles, as well as the count of facilities of each type. And then we can continue going all the way to a street level to figure out where there may be those facilities. So this is actually my neighborhood. I live around here, and this is a couple of community pharmacies, and this is a federally qualified health center. In each of them, when you overlay the mouse over the facilities, you can see the full address so that you can know where the facilities are and what are their names. And if you are only looking for a specific type of facility, you can, for instance, select here community pharmacies, and then you will see where there are community pharmacies in a certain area.
Wow, this is really great. I have to just say thank you on behalf of like everyone in America. Like this should be super useful. Like you mentioned the risk score as a way of stratifying people who, or places where there's a low density of potential vaccine administration sites, but also high driving distance. And I think you make some potential like recommendations or ideas for or thoughts around like how some of these high risk areas can kind of combat this issue. And I think this is interesting because I think this dashboard is so great of a tool that public health officials and politicians and government should be able to use it. And what should someone in charge of distributing the vaccine in these sort of high risk areas take away from that map, and what can they do?
Before I take that question, I want to say something before I forget. You said that you are thankful, and I want to say that we are very thankful to West Health Policy Center, which is the funder of this project. They are a great partner in research, and we have worked together in some of their projects. And, you know, it's very hard for researchers like us to find funding in a very timely manner to do like projects when, you know, they are relevant, because sometimes funders have like very long review timelines. So then, you know, if we had submitted this in September, probably we wouldn't have had the funding to do this in a timely manner. So we were very lucky that West Health Policy Center thought this was an important idea, again, to guide public health planning efforts, and they decided to fund this, and they are truly the funder behind this that have enabled us to do the project. So we're very, very thankful to them. And now I will take the question about the measures that we recommend for public health officials on those high-risk counties. So I think we're suggesting a couple of things. If we have a county where there's low facility density because it's an urban county with high population but low driving distance, probably mass immunization clinics like stadiums, convention centers would make sense. However, that's not the case of these counties in Nebraska, Kansas, or Montana, where again, we have low facility density and high driving distances. We think that in these cases, travel vans may be interesting, and we think that it may be important to save the Johnson & Johnson vaccines to reach these especially at-risk counties, because These are folks that, again, we have very far. We have a high proportion of the county population in a very far distance. And we have low resources because we know we have a low facility density. So we think that in these cases of special high risk, it may be a good idea to use the Johnson & Johnson vaccines, since they only require one dose, and then we could be, it would be easier to reach these folks once rather than reach these folks twice. It's probably easier to get, in urban counties, people to come twice if they have lower barriers to access. So we think that this data can be used not only in figuring out like where to open vaccine immunization clinics or, or where to put travel bans, but also in allocating the types of vaccines to each county based, again, on the limitations of the local infrastructure.
Yeah, that's really interesting. I hadn't thought about that. So not just different sort of distribution strategies like vans and mobile clinics or stadiums, but actually which vaccine you use in certain areas.
For full honesty, since we are colleagues, I haven't thought about that either. This is the idea of our one of the co-authors of our paper, who is actually with West Health Policy Center. As I said, this is a truly research partnership where we have authorship in both sides and where we have developed this together. And I think it's an excellent and bright point that I hope policymakers can take into account.
Yeah, and I wonder if there's like, I know the Johnson & Johnson vaccine has easier or less stringent temperature requirements and storage requirements, which may be advantageous in a sort of traveling van situation. But, you keep going back to this Westpac Health, right?
West Health Policy Center.
Oh, West Health Policy Center. I think this is really interesting, and this wasn't the planned topic, but I think it's really good insight into sort of like how academic research typically gets done versus how it can be done maybe better in this sort of pandemic setting. And so is that, you mentioned they were able to help fund and help get this done quickly as opposed to these longer cycles typically with maybe government grants. But is that also, I'm curious, one of the reasons why you released this as like an open access website with a white paper versus like in a journal, for example?
Yes, so obviously as academics, it's better for us to have on the CV a peer review paper than a white paper, but we thought it was of the essence to have the data publicly available as soon as possible. So we thought that we had to do a white paper to save that time of peer review. We do understand, and there's been a lot of controversy in this pandemic with the issue of preprints and non-peer-reviewed papers, because truly, I do agree they may not be as robust in the sense that it's always better to have an additional set of eyes. And I think many papers improve a lot through the peer review process, truly. But we discussed this internally. We even talked with some of our communications team who have been very involved in releasing the research results that PET as an institution has done in COVID, not only in vaccines, but in everything. And we believe that the priority here was to get this information out as soon as possible so that policymakers and public health officials could use it. And that's why we decided to do a white paper. We actually released a first version of the dashboard and a first version of the white paper the last week of December. And then we continue working over Christmas on adding a few extra analyses and also adding that facility dashboard. And we just released it last week again with the idea that we really need to publish the data as we have it, obviously after doing our due diligence and certainly doing accuracy checks, but we felt we maybe didn't have the luxury of waiting for peer review.
Yeah, I mean, this is just my personal opinion, but I mean, I think it's absolutely the right call and the right thing to do. And you're seeing it, like you said, all across the board in science right now, with the preprints being so ubiquitous and sometimes science by press release, all of these things are definitely being talked about and people are going back and forth on what's the most appropriate. But, I think I agree speed is of the essence. But anyway, I'm not an expert on publications. I just thought it was kind of curious.
No, me neither, to be honest. And I think, there was a lot of controversy in, early 2020 with some of the first trials, with some of the first observational studies. I think it's been terribly interesting and at the same time challenging to do science. I think it's terribly interesting because also for healthcare professionals like us, because I think everybody now can see how important healthcare is as a pillar of society, and also how relevant science is, and truly that we are nothing without science. This vaccine is truly going to be the scientific achievement of, I don't know if maybe of the century, but certainly of many years. Having said that, I think it's been it's been a terribly challenging time to live as human being. We have all had our issues in 2020, me the first one. But it's been a beautiful time to live as a scientist, because I think it's brought up many, many things that we often don't think of that much. And certainly the issue of timing of publications has been a controversy. I think there's no right or wrong answer. It certainly hurts and has hurt to release information too early in some cases. We thought this was not, I thought this was different than maybe comparing a treatment or, the efficacy of a vaccine. This was just about identifying counties where we had low access to facilities. We may not have had a peer-reviewed paper. We may not have done all the analysis in the world that one could think of, but we thought that the information we were releasing could be helpful, and that's why we wanted to get it out.
Yeah. I mean, that's a good point. It's not like a treatment where if the risk of being wrong is like incredibly dangerous, for example. And I think the potential use for policymakers and public health officials is really important. And even just going back to the fact that it's a dashboard that you can interact with, like this is something I could potentially see the local health department, using, or the state health department using to identify different counties where they need to place a renewed focus on. Have you had the opportunity to speak to any health departments or public health officials, or maybe your partners?
So we did get a consult from the Virginia Public Health Department last week. And we do know that some of the press that covered our paper shared it with the Georgia Public Health Department, because unfortunately Atlanta metropolitan city was the place where we found the largest racial disparities, which is unfortunate. And one of the members of our team, Dr. Kim Colley, who I think you know, is also involved in some of the planning efforts at the Pennsylvania State Department. So we haven't officially shared with them, but she's a member in both sides. So I'm sure they are aware of our findings. And looking forward to, as you were saying, to hopefully having more state departments and local health departments using our data. We did wanted to do as broad of a dissemination as possible. And that's why, I'm very happy that you invited me to this podcast, because the point of the data is to help and to be used and to be useful. So we wanted this to get the attention of as many people as possible, so that hopefully it can help in those planning efforts that we know are challenging, but they are also very important.
Yeah, definitely. I think, I'm very happy to have you here. I think I'm gonna maybe write an email and just copy and paste it to all the different counties that are highlighted in red on the map, and hopefully get their eyes on it.
We also, last week, we got some coverage from NPR, and our data was coupled with field investigation in Louisiana, Texas, and Georgia, I believe. And I know that some of those reporters have been in contact with them. So we have been very happy that, to see our data combined with actually efforts in the field. And we're hoping that some of those local counties look at the data, and again,
try to figure out ways, innovative ways to add additional resources in those high-risk areas. We realize that unfortunately this is not, this is not about blaming them. It's certainly not their fault. Unfortunately, the disparities that we see represent ongoing disparities in access, right? Because we're just plotting healthcare infrastructure. So we are showing where the healthcare infrastructure of this country is. And unfortunately, in some socially disadvantaged counties, healthcare infrastructure is not as strong. And that's not the blame of the health departments. That's certainly not, but we don't want this data to inform their planning efforts so that hopefully we can mitigate these disparities and achieve an equitable vaccine distribution, which I think is of the essence in this rollout.
Yeah, it's really unfortunate, and not just the infrastructure. The infrastructure is like the next piece that we're finding out now, or at least I am, is another disparity which you and your colleagues highlighted, but it's really infuriating almost, because just looking at the pandemic, even before the vaccine came out, you saw, I can't speak to all communities, but I know in the Hispanic and Black American communities, the risk of getting the infection in the first place is much higher. The risk of hospitalization is much higher. The risk of death is much higher. And there's just so many contributing factors, everything from occupational hazards to comorbidity prevalence, and there's just so many different elements to it. And then on top of that, now we have a vaccine. This is like supposed to be the saving grace, and you have major challenges ahead as far as getting the vaccine to people. And you see that data is coming out too now. I've seen some reports about the rates of vaccination in Hispanic and Black communities are also reduced. So definitely major challenges ahead. And I hope that some of these strategies you talk about are looked into. And I think because there's so many different causes, there's probably going to need to be several different types of solutions to sort of figure it out.
Yeah, I think that's a very good point. We're already aware of some local strategies, opening vaccination locations in some underserved neighborhoods. I think in Pittsburgh, I believe actually the University of Pittsburgh is opening, I think it's one location, and then Duquesne University is opening another location in some of these underserved neighborhoods. Last week, we talked with the Philadelphia Inquirer, and they also told us of a similar strategy. So I think we're gonna need these types of strategies. However, I would also like our data to bring attention to the long-term issue that, if we don't mitigate these disparities, they are going to exist there. Because again, this is not, this is about COVID vaccine, don't get me wrong, that's what we did the study. But the data actually shows disparities in healthcare infrastructure that, where patients can access medical services for things other than COVID. And we're seeing large disparities. So I'm hoping that the data will also be able to inform long-term solutions, in the sense of maybe hopefully like opening facilities in some of those underserved neighborhoods, improving transportation, improving healthcare access in some other ways. So I agree, we're going to need those patches for, to achieve an equitable vaccine distribution, but we really, really also need to work on fixing this long-term. And you made a very good point earlier on that unfortunately disparities are not only about this vaccine rollout. We have had terrible disparities in COVID infection rates and outcomes since the start of the beginning of the pandemic. And I think simply we cannot afford disparities to exacerbate any further. It's outside of magnitude and control. And I do think this is the current public health priority for everyone.
Yeah, absolutely. And you hit the nail on the head. It's yes, the paper and the study was technically about vaccines, and but you really could just erase the title and say health service centers. The geographical distribution of health service locations in the United States, and it would show very similar results. Pharmacies, I believe, outpatient clinics, federally FHRQs. What do they stand for again?
Federally qualified health centers.
Yes. So these are all places where people get health services, and the same thing that's true for vaccines, as you just mentioned, is true for other services as well. It's a difficult problem, and I hope this wakes people up and start to reinvest in building that infrastructure out. Are you aware of anything that is sort of changing moving forward to help rebuild that structure, or is because in this sort of discussion with health disparities in general across the country, you often hear about these disparities and inequalities. And what I find lacking, and maybe this is just my own ignorance, but I find that you don't really hear how it's changing. You just hear about the problems over and over, and you just wonder, like, what is being done to fix it? Do you have any information on that?
I agree. I'll speak to what I know, which is the research community. I think recently the research community has acknowledged that too much of the work in this area has been about describing the disparities and too little or nothing about, mitigating them. And I think truly now in all of the research efforts in the area, there's increased emphasis on solutions, on policy interventions. Mm-hmm. We already know that disparities exist. We don't need any more research to document it. I mean, don't get me wrong, because I'm still doing research to document this. But, the point is that we need to move on to the action phase. I don't have a role on a health system or a policy, maker. So I'm not as updated on maybe what efforts are being done on those areas. I know that, Pittsburgh has recently seen the creation of some of these health centers in some of the socially disadvantaged neighborhoods. Again, our university has been involved in that. And I think that's terrific, but I don't know, what's the scope of the change at the nation level, unfortunately.
Yeah. Totally makes sense. And and I think it's interesting because you mentioned that the health component of it, and that's a huge part of it. Obviously we're talking about health disparities, but even, your study itself looks at the driving distance for people. Even things like transportation become major problems that impact the health of the population. So it's just so far reaching.
And we think that it's precisely some of those barriers that actually make it hard to access healthcare. Mm-hmm. If everybody owns a car, it may not be that big of a deal to drive 2, 3, or 5 miles. But I didn't have a car when I was in grad school. I lived in Pittsburgh. The grocery shop was across the bridge, which meant I couldn't walk. And it was an ordeal to basically go for groceries because, the bus, at that time there were no apps. You didn't know when the bus was going to come. You had to wait 30 minutes on freezing cold to take the bus to go for groceries and then wait again. It was truly an ordeal. And it was a short, if you measure on the map, it was probably no more than 1 mile, but it was truly, it was hard to get around. And I think this is the point, that some of the communities that we are highlighting, have lower rates of car ownership. Public transportation may not be the best, especially now in the setting of COVID, which we know that public transportation doesn't come as frequent. So it's just a perfect storm.
Yeah, definitely. I wanted to ask you about if you have any plans to continue and build upon this work. Is there a VaxMap 3.0 in the works?
We have been asked about this. When we released VaxMap 1.0, we knew that we had a few things left to do, and we knew 2.0. Although I have to say that some of the things we did them based on the feedback that we got when we released the first version. Mm-hmm. So I think we want people to use VaxMap 2.0, see what, other things may be helpful to keep building on it. So as of now, I think there's a few more analyses we can do, more in the form of papers, from the analysis that we have built. But in terms of the dashboard, I think it may depend on whether there's something that truly may be important. Again, we wanted this to be a tool used in public health planning. And that's why we weren't originally thinking of updating results based on where the vaccines go. Also because we know that some of the media are doing maps with, where the vaccines are going. So we wanted this to have like a different use and different application.
Yeah, that makes sense. I mean, I think this is just my personal opinion, but I think it could go on the CDC website and be more broadly seen across the country. I saw, so the CDC has like a health disparity page, and it talks mostly about the disease itself. It doesn't talk about the vaccines really. Maybe that's, pending more data coming in. But I think a dashboard like this could be really helpful for everyone to see, even just to get a better understanding of where, one, just knowing that the disparities exist if they don't already know already, and two, knowing where maybe more focus can be, or maybe if you're a resident of a certain area, knowing that you might have to plan for a 1-hour trip or something, or get in contact with your health department to see if they have any strategies for when your turn comes around to get the vaccine. So that's just one idea I have. I'm sure there's other things that you have in the works as you described.
We wanted to see how people start using it, where I think is still in the dissemination phase of VaxMap, and we would love to have some feedback from users and public health officials as of what else may be helpful. We built VaxMap thinking about the information that we thought may be helpful. Again, like, going, what type of facility. If you are just looking for pharmacies, you can just select pharmacies. If if for some reason, I don't know, you are looking for a hospital patient department, you can just look for that. And also, again, to go all the way to the street level and to be able to see the full contact information like the name and the address. And same thing with the county data. In both dashboards, you can see all the county data so that people can see how it compares. But again, looking forward to having some feedback to see if we can make the tool more useful.
Yeah, I'm sure you'll be able to build on any feedback you get. I mean, you're a great researcher. I actually wanted to end by sort of talking about yourself a little bit and some of your expertise. I personally know you through, you were my professor for pharmacoepidemiology. Could you talk about how the study of pharmacoepidemiology kind of like prepared you for this, or, what's the relevance of that for this sort of study?
So I guess our work is mostly about using large data sources in understanding drug use and drug outcomes once a drug gets to the market, right? So I think the clinical trial world covers phase 1 through 3. We say that we do phase 4, but it's not only about comparing drugs or about tracking the safety of a new product. It's also about understanding medication use in the real world, barriers to access, and why some people use drugs and some people don't. We had been thinking for a while about doing a geographic information systems analysis, and this just happened to be the best context to do it, for a very helpful application. And again, I think this is pharmacoepi, maybe not doing a regression. This is doing pharmacoepi with a geographic information systems analysis, which is much more cool. And because the point is to measure determinants of drug use, right? And in this case, the determinant is access to a facility where you may get a drug. So I know that people may not think of this as pharmacoepidemiology, but I think it does relate to the science of using data to understanding access, use of medications, and outcomes in the real world.
Yeah, I think I think that's a great summary, and I think it's interesting because so many people have had to kind of adapt, and you've seen all sorts of people from so many different backgrounds all of a sudden jump into COVID research. People with the physics community looking at fluid dynamics and how aerosols travel, and you've seen microbiologists, obviously, and virologists. And so, yeah, everyone's adapting, and how can my skill set, best serve the public health. Even, Pennsylvania allowed pharmacy students to start vaccinating, and you have basically everyone, all hands on deck. And it's, unfortunately, it's because of tragic circumstances, but in some ways it's been kind of amazing to watch kind of everyone join the call to action.
It's been a terrible, very difficult time to live through, but I think in professional terms, it's sad, as you say, that a tragedy like this has to happen to realize how we can work in a different way. But it's been a terribly exciting time to research, as it's been, for instance, as a pharmacist, I think the role of the pharmacist is going to be certainly highlighted in this pandemic in vaccine administration. And again, it's sad that this has to happen, for us to realize it, but at least it's a silver lining of the pandemic. So we need to take the positives that the pandemic has brought, because it certainly has had a lot of negatives.
Yeah, for sure. Is there anything you wanted to share with the audience before we wrap up for the day?
I'm just very excited and honored to be here in this podcast. Thank you for giving us the opportunity to talk a little bit more about VaxMap, how it came to be and how we envision it. And I'm just hoping that the users will be able to access it and find it useful. And our contact information is available in the university's website. So if anybody has any questions, please feel free to reach out. I think podcasts are also very important in making science available to all. So I think scientists also have to be available to all. So please, if anybody has any questions or has any follow-up ideas in mind, I could be very happy to take them by email. And thank you all for having me.
Yeah, I'll include all of the relevant information along with the episode, and truly it's been my honor. So thank you so much for me.
I've enjoyed the conversation very much. It's been terrific.
Hey everyone, thanks for listening. I hope you enjoyed the show. Please make sure to check out the show notes to learn more about Dr. Hernandez, as well as so you can view that interactive dashboard that we showed and the one that we talked about on the show. I think it's really important to share that and get more eyeballs on that map. It's really important work. So please go ahead and give it a share if you get the opportunity. Thanks and take care.